So we will. We're at 46 participants so far. We're right now at noon. I'm sure that people will be joining in as we go along. But we are not going to open it up for questions. We muted you all so that, not that we don't want to hear from you, we really want to hear from you, but otherwise it can be a lot of feedback on the calls. I'm sure many of you are already well aware of Zoom calls and what they can be like. And we'd like to use Slido for questions instead of the chat, although I suppose you could use that too. So if you have a question, please log on to Slido and use the event code hashtag WHRC, but Karen and Paul will be showing you that again for your information. I'm going to start in the interest of time. So I'm so excited to present to introduce our two fabulous speakers. We have two for the price of one, which is great. And I'm so happy that they've agreed to do this online so that we can still continue to communicate for the cluster, the Women's Health Research Cluster. And I'm going to give you a tiny brief bio. You're going to see me looking at my other screen here, and then tell you a fun fact about them. So Paul is a co-founder and principal investigator for SOAR, which stands for, and I think you'll see it on the screen there, Supporting Survivors of Abuse and Brain Injury Through Research. He's also a professor in the School of Health and Exercise Sciences at UBCO Okanagan campus in Kelowna, and I hear it's warm and going to be maybe sunny and 21 degrees today, so we're very lucky to have them staying inside when it's such a beautiful day. His research focuses on the basic mechanisms of sensory motor control and cardiovascular, neurocognitive, and sensory motor aspects of brain dysfunction resulting from TBI or traumatic brain injury. And since 2016, he's been a fairly recent convert to understanding women's brain health, and especially for women who've experienced interpartner violence related to TBI in collaboration with the Kelowna Women's Shelter through the SOAR project. Karen is a co-founder and director of the community practice for SOAR and former executive director of the Kelowna Women's Shelter in British Columbia, which provides emergency and transitional housing, supported second stage housing, counseling support, advocacy, and prevention and education to women and women with children who've experienced gender-based violence. In collaboration with the University of British Columbia's Okanagan campus, the shelter is engaged in community-based SOAR research project to better understand the intersection of TBI, brain injury, and intimate partner violence. So I always ask for a fun fact from our speakers, and it's always great when we get real fun facts. And so for Paul, his fun fact is that he was a competitive cross-country skier. I want to know the was part. And Karen is a part of a vintage singing trio. Very interesting, and be very fascinating to know what kind of singing as well. And so without further ado, I give it over to Paul and Karen.
Thank you, Lisa, and thanks everybody for being here. I can't see you, but thank you virtually for showing up. I really kind of wonder how many of you are in pajamas right now, and if you are, I salute you. I have to admit that it's only because of this event that I actually blow-dried my hair and put on makeup, which frankly I thought I'd forgotten how to do. So if I look overdone, that's why. I haven't worn makeup in probably a month. Anyway, we're really happy to be here and grateful that you're here to listen to our talk about intimate partner violence and brain injury.
So first of all, we wanted to let you know that we're going to be using Slido as a mechanism by which to post questions about the talk. If you go to the Slido website in your browser and type in the WHRC hashtag, it will get you to the one that's specific for this particular talk, or you can use the QR code indicated on the right-hand side of this slide.
So before we get started, I have kind of an interesting question. Now again, you're not in a big room and I can't see your answers, but if you want to raise your hand in the privacy of your own home office or wherever you're working, feel free. It's a little odd, but we will get to why in a second. Is any of you single?
And how many of you might be using online dating sites like those that we've listed here and wondering how that might be going, especially in these strange times?
So we hope by the end of this presentation that not only are we going to leave you with some really interesting and important information, but that we can also give you a little bit of hope. But we'll get back to that.
So first of all, a little bit about ourselves. Lisa's already mentioned that I'm a professor in the School of Health and Exercise Sciences at the Okanagan campus of UBC. And I've spent about 20 years now examining the effects of head impacts and concussion in athletes using objective measures of things like cerebral blood flow, cognitive function, sensory motor function, and blood biomarkers.
And I am the former executive director from Kelowna Women's Shelter. I was there for almost 6 years, left just this past September to focus on this work. The Kelowna Women's Shelter provides emergency and transitional housing for women and women with children who are fleeing intimate partner violence. Women can stay there for up to 30 days while they seek a safe place to live and get their lives in order. The reality is there are so few affordable safe places for women and children in our province, in our communities, that many women end up staying longer than 30 days. The shelter also operates a 24-hour crisis line, has some supported second stage housing, which is specifically for women who have spent time in the shelter or transition house and then have been moved into this supported housing where they can get counseling for another year or a year and a half before they move out completely on their own. The shelter also, like many women's shelters and transition houses across this country, offers free counseling and advocacy for women who stay at the shelter or in the community. You don't need to stay at most women's shelters to benefit from the services. They do serve a lot of women in the community who need support, whether it's with counseling or creating a safety plan in order to get out of a violent situation, or with ongoing support after leaving a violent situation. Kelowna Women's Shelter also does some programming supporting children and youth. We know that children who witness abuse are twice as likely to grow up and become victims themselves or abusers. So getting to children at a young age and supporting them if they've witnessed abuse, and also working with youth to help them understand what healthy relationships look like and what they don't look like are really important goals for organizations like Kelowna Women's Shelter. And the shelter also operates a very successful thrift store. And if this were, normal times and you were seeing me in a work context frequently, I'd be telling you almost every day what outfit I bought at Kelowna Women's Shelter thrift store. It's a fabulous way to get out in the community and support the shelter and the work that it does. So getting to some facts about intimate partner violence, most incidents of intimate partner violence do involve blows to the face, head, and neck. So therefore, it does stand to reason that as many as 92% of survivors may also have suffered some kind of brain injury.
But what do we often hear about in the media, and that is sports concussion. There's a lot of research and a lot of interest in how we make sports safer for young athletes, how professional football players and hockey players in particular may be suffering from the consequences of one or more concussions or repetitive head impacts over the course of their careers.
But consider this. The Centers for Disease Control in the United States says that every year in the United States, 2.3% of women will experience a severe incident of intimate partner violence. So if we translate that 2.3% into Canada and our statistics, that means 230,000 women in Canada will experience a severe incident of intimate partner violence every year. So if you look at that 92% number, that means 212,000 Canadian women or more may experience a brain injury because of intimate partner violence every single year. So when we talk about sports concussion and all the coverage we see of sports concussion and all the research that's been done to date on sports concussion, we want to let you know how that compares statistically. So for every one NHL player who suffers a concussion every year, and that's about 38 a year, more than 5,500 Canadian women are probably suffering the same or similar injury due to their intimate partner. It's shocking, and yet we hardly ever hear about it.
So just to get some foundational background on what is a brain injury, it's defined as an alteration in brain function caused by external forces, i.e. impact to the head or to the body that it gets transmitted into the head, or a reduction in oxygen supply that can occur through a variety of means. And so it's a form of brain injury caused by this impact or jolt to the head, neck, or body that causes the head and brain to move rapidly back and forth, and the brain specifically to move a little bit inside the cranial vault. And that movement inside the cranial vault is the thing that typically results in the injuries that we see. In the context of intimate partner violence, brain injury can also happen with strangulation. And there, the injury isn't due to an impact or a force, it's due to the cutting off of the blood supply and the oxygen that comes along with it.
So in intimate partner violence, there are a variety of mechanisms by which a brain injury can occur. And those of you in the audience who are familiar with intimate partner violence will be familiar with all of these sorts of injury mechanisms. Sometimes a woman is punched or hit in the head, either with a fist or some kind of object. She might be kicked in the head. That's fairly common, unfortunately. Violently shaken, pushed downstairs or pushed onto the floor, thrown out of a moving vehicle, or, as Paul had mentioned in the previous slide, strangled. In fact, we know that at least 50% of women who've been in intimate partner violence report having been strangled, and it is a huge red flag for future fatality. So it's a really important one that can cause severe brain injury and can potentially lead to a fatality.
Now, the challenge with brain injury is that it's an invisible injury. So it's not like an orthopedic injury, say, where you break a bone or you bust your knee and you need surgery to repair it. You can't really see the injury on most clinical tests, and so best practice from physicians and other healthcare providers is to rely on signs and symptoms. So you'll end up with people complaining about things like headaches or fatigue or difficulty sleeping. There's quite often some emotional disturbances like worries and fears or depression and sadness. And quite often there can also be issues around sensitivity to sensory stimulation like light and noise.
Now, in the context of intimate partner violence, how these symptoms and signs might manifest themselves is the survivor might appear to not listen and remember things, might be easily distracted, have difficulty learning, trouble with instructions, forgetting appointments or chores. Any of you who've worked in the gender-based violence sector or in a shelter setting know that sometimes you have residents who just can't remember the chores or appointments they're supposed to do, and how incredibly frustrating that can be for the staff who are trying really hard to support all the women in shelter and to make sure things get done. They can get tired and really irritated quite easily, perhaps more irritated more easily by their children or other people's children. They might have issues adapting to various situations, but particularly to life in a communal setting like a women's shelter transition house. And they might change their story frequently, really because they don't necessarily know and don't remember portions of their story. So now I just want to take you back to the online dating question from the beginning. So 5 years ago, there I am, a middle-aged, single, executive director of a women's shelter, and there's Paul, a middle-aged, single concussion researcher. And we, like good single middle-aged people, are online dating. And one day, we both swiped right on Tinder, of all places. And we met, we fell in love, because look at him. He's not only smart, he's very cute, and I'm 5'9". He's 6'4". I can wear my 4-inch heels and not tower over him, so that's a bonus just in and of itself. So we met, fell in love, started dating, and a few months after we started dating, I read this article. And this article talks about the connection between brain injury and intimate partner violence. It is an opinion piece written by a woman who at the time was the head of one of the largest women's shelters in Arizona, and she was writing about her personal story with her mother, who died young of early onset Alzheimer's disease and had suffered a lot of effects of brain injury from living with her father, who was a chronic and severe abuser. So I saw this article and I immediately forwarded it to Paul and said, what are we doing researching athletes? We need to research women right now.
And so together we were able to create this project called SOAR, which stands for Supporting Survivors of Abuse and Brain Injury Through Research. And you can go to the soarproject.ca website to learn more about it. We've been fortunate to obtain some anonymous donor funding fairly early on in the project that allowed us to get it off the ground. So what is it? Well, it's a community engaged project that is by definition multidisciplinary and aimed at partnering with community agencies like mainly the Kelowna Women's Shelter. It was launched in 2016 as this partnership between UBCO Okanagan and Kelowna Women's Shelter, and we started data collection in 2017, basically about 3 years ago now. And it's got 3 different goals. The first is to explore, and that is the basic assessment and characterization of the incidence and effects of traumatic brain injury and intimate partner violence, and we'll get into some detail about what that's all about. The second phase is to educate, so to get evidence-based information and trainings out to people who work directly with survivors of intimate partner violence, so they have a better picture of how traumatic brain injury might be part of that experience. And then the third phase is called Empower, and that's to create better awareness and support services so that we can actually create programming that will help survivors by taking traumatic brain injury into account.
So we'll start with phase 1, which is the explore phase, and this one's really about figuring out the incidence of brain injury in survivors of intimate partner violence. So these start in the first portion of phase 1 with psychosocial assessments that are all conducted at the premises of Kelowna Women's Shelter. And these assessments are a one-on-one interview that takes about 2 hours at the most, and they do assessments of post-traumatic stress disorder, anxiety, depression, trauma history, substance abuse, and they also look at something called the Brain Injury Severity Assessment that Paul will tell you about.
And it's really important to assess these components, these comorbidities, as we call them, because they are very prevalent in women who've experienced intimate partner violence. Not to say that they're not prevalent in athletes and young athletes who might get a sports concussion. Absolutely, it happens in a certain proportion of that population as well, but definitely something that needs to be considered and taken into account after a woman's experienced intimate partner violence. So the Brain Injury Severity Assessment Tool, or the BISA, asks a series of questions related to the incidence of intimate partner violence that resulted in TBI-like symptoms. So for example, a question might be something along the lines of, after an episode with your partner, did you see stars afterwards? Or did you have difficulty sleeping afterwards? Or did you have difficulty concentrating or paying attention afterwards? And if the answer is yes, which quite often it is, then there's follow-up questions related to how frequently that happened, how long the symptoms or the signs lasted, what was the first time it happened in your life versus the most recent time, and how severe were those symptoms in terms of things like loss of consciousness or post-traumatic amnesia. So with the BISA, you end up with a score from 0 to 8, where 0 means that the woman has been exposed to intimate partner violence, but if it was physical, it was directed to some other part of the body other than the head, face, or neck, or it may have been emotional, financial, or sexual abuse. 8, on the other hand, means that intimate partner violence involved violence directed at the head, face, or neck. It was quite frequent. The most recent time was not very long ago, and quite often it resulted in loss of consciousness or post-traumatic amnesia. So after we do all of these questionnaires at the Women's Shelter, we bring them up to the lab at UBCO Okanagan, and we do a variety of assessments of brain function. One of the key ones that we do in my lab is measures of brain blood flow. And so this image here on the left shows the equipment that's used to assess brain blood flow. And one of the approaches that we use is to look at the relationship between systemic blood pressure and cerebral blood velocity. And so that's shown in this trace here with blood pressure on top in blue and cerebral blood velocity in the bottom in red. And you can see that there's very frequent movements of this trace up and down. Those represent each beat of the heart. And then overlapping on top of this is a much slower change in terms of the up and down of the waveform. And that's induced by having the participant perform a series of stand squat maneuvers. And the effect that this has is that it changes systemic blood pressure. So when you squat down, your blood pressure goes up. Oops. And when you stand back up, your blood pressure goes back down. then what we can do is monitor how cerebral blood velocity changes in response to this change in systemic blood pressure. And this is a process called cerebral autoregulation. So it's the regulation of the blood velocity going into the brain as it pertains to changes in systemic blood pressure. And what you can see is that the two move together, although there's some movement of the cerebral blood velocity earlier in time relative to the change in systemic blood pressure. And what we can do is use some transform function analysis to look at the relationship between these two curves represented in the black line. So we can look at things like phase and gain to get a sense of how much of the change in systemic blood pressure is making its way into the cerebral blood velocity signal. We can also use a piece of equipment in the lab called the kin arm, which is a bimanual robotic device where a participant can engage with visually presented targets in a variety of different tasks. One of the tasks that we use is called the object hit and avoid task. So in this task, the participant grabs the handles of the robot arm and attempts to hit targets as they fall from the top of the screen. They also, at the same time, tried to avoid targets that they're meant to avoid. And so in this particular video segment, the participants meant to hit the vertical rectangles and the circles, I believe, and avoid all the other objects as they descend. So I'll show this segment just to give you a sense of the difficulty of this task. So you can see that they were fairly successful at hitting most of the targets as they descended and avoiding most of the non-targets. And what they're meant to do is to, as the targets fall faster and faster as the trial progresses, obviously it gets harder and harder to perform this task and they start to make errors. And so we can measure those errors and get a sense of how well they're able to inhibit unwanted responses while still hitting as many targets as they can. So the first thing we looked at was just the number of symptoms that the person reported on the day they showed up at the lab. And for this task, we used the Sport Concussion Assessment Tool, which is kind of the gold standard for young athletes who've suffered or suspected to have been suffered sports concussion. And one of the advantages of this is we can compare the data from the survivors of intimate partner violence directly to what we've seen previously in young athletes. So on the left-hand side of the screen here, we've got the number of symptoms from the SCAT assessment in young athletes at baseline pre-season versus within 3 days of being diagnosed, sorry about that, with a concussion. And you can see you get a huge increase in the number of symptoms immediately after a concussion, which is one of the cardinal signs that a person's had a concussion. So they go from about 2 or 3 symptoms at baseline to just over 10 within 3 days of the injury. On the far right of the graph, we've got the data for the intimate partner violence survivors, and you can see that they have as many or more symptoms at the point of testing as the young athletes within 3 days of their injury. We've got some data here from matched controls. They're matched in terms of, sorry about this, age and education level, but they've suffered neither intimate partner violence nor traumatic brain injury, and you can see that they have a reduced number of symptoms compared to the IPV survivors. Now, the interesting and scary thing about this data for the IPV survivors is that the earliest we saw one of the participants was 3 months after the most recent episode of IPV, and the median time after which we saw the survivors in the lab was about a year. And so clearly these symptoms are chronic in nature. They're living with them every day compared to what you see in sports concussion, where absolutely they have an increase in the number of symptoms immediately after the injury, but then that tends to be reduced to more baseline levels as time progresses over the following week to 10 days or so. In terms of the cerebral autoregulation, what we found was that there was a greater level of IPV, the greater the level of IPV-related traumatic brain injury, the greater the disruption to cerebral autoregulation. So that relationship between systemic blood pressure and cerebral blood velocity was disrupted. And so this is actually consistent with increased stiffening in the brain blood vessels, which has been linked to an increased incidence of stroke and dementia in those patient populations. And so this points to the possibility that being exposed to IPV-related traumatic brain injury may actually be a precursor to longer-term neurological disorders like stroke and dementia. Finally, for the object hit and avoid task, here we compared the data from the intimate partner violence survivors to a group of soccer players who we exposed to 20 minutes of soccer heading. And the dependent variable that we are looking at here is something we call the aborted distractor hits. So I don't know if you saw it in the video segment, but I think at least on one of the attempts, the person started to move towards one of the non-targets or the distractors, and then stopped themselves. So they aborted that attempt to hit a distractor. And so this dependent variable is reflective of the person's ability to inhibit unwanted responses, but not completely. So they start the response and then are able to stop themselves. And so what we can see is that compared to soccer players who just headed the ball for 20 minutes, survivors of intimate partner violence have an increased number of aborted distractor hits. And so they definitely have some challenges in terms of inhibiting unwanted responses. So to summarize then, the majority of participants have experienced intimate partner violence-related traumatic brain injury. We had very few of our participants who scored 0 on the visa. The number of symptoms that they exhibited at the time of testing was greater than that observed in acute sport-related concussion, and so that clearly indicates that they're living with these symptoms in a chronic way. In terms of cerebral autoregulation, there was evidence of arterial stiffening induced by IPV-related TBI that has been linked to longer-term neurodegeneration. And there was a reduction in the ability to inhibit unwanted responses in the object hit and avoid task. So the bottom line is these women are being exposed to repeated traumatic brain injuries that lead to chronic symptoms that likely have long-term consequences.
So what do we do about it? When we started this project and started exploring the science piece, we realized that it was not going to be helpful to understand how broad the scope of this issue was if we weren't able to do something about it. So phase 2 is the educate phase, where we're working on education and training for frontline workers in women's shelters and others who work directly with women who've experienced intimate partner violence. We initially did a survey of 150 shelter workers from across the country, and we were trying to find out what they knew about brain injury, what they didn't know about brain injury, if they were screening for brain injury as a part of their daily practice in shelter, if they weren't, and if they were going to learn about brain injury and intimate partner violence, what they wanted to know and how they wanted to find out. So the survey found that at least 75% of those who work in shelters across Canada have never done a formal screening for brain injury with their clients. That's despite some of the numbers we showed you earlier in this presentation that show probably almost every woman they're working with may have experienced a brain injury. So the next step was for us to then review what sorts of brain injury screening tools are out there to try and get a sense of if there was already one we might use at a shelter setting, and if not, could we find one and adapt it for use in a shelter setting. As part of that, we did interviews with workers at Kelowna Women's Shelter, showed them some of the top screening tools, and got their feedback on what they thought would actually work in their day-to-day, which is already incredibly busy. So this is the final one that we came up with. It's called the HELPS tool. It's been around for a long time. This is a slightly adapted version where we've added a piece about strangulation because, again, as we mentioned earlier in the presentation, it's a pretty major factor in intimate partner violence that does contribute to brain injury. So this tool goes through a series of 5 questions or topic areas, the first one being about being hit, or being shaken roughly, and strangulation. The second, have you ever been seen in an emergency room? For the E, basically, have you seen a doctor or have you wanted to see a doctor but have not? The L is for lose consciousness, or experiencing a time of being dazed and confused because of something your partner did to you. P is for problems, and it goes through a list of the kinds of problems or issues the woman may have experienced if she has potentially a head injury. And then the S is for sickness or symptoms, and it goes through the sorts of things the woman might have experienced, again, because she may have experienced a brain injury. So the idea with this tool is to use it as a way to form a conversation around brain injury. It doesn't necessarily have to be done in a formal way with a woman who's at a women's shelter. It can just guide the conversation, and it doesn't diagnose a brain injury. We're not asking anyone to do that. The expertise isn't there. But it does give you a sense of if there are red flags and whether you should be moving forward in such a way that would then support someone who has experienced a brain injury. The next piece in the educate phase is to take what we've learned and create some training materials and to create workshops that we can deliver to not only workers at women's shelters, but others who support women who've experienced intimate partner violence. And one of the training pieces that we are almost done developing is a module specific to intimate partner violence as part of this tool, which is the Concussion Awareness Training Tool. The CAT already exists and is a proven training tool for those who want to learn about concussion. There are different modules for different types of people, whether you are a medical professional, a coach, or a participant or a sports player who may have experienced brain injury. There's also a more recent one for workers to do with concussion experienced in the workplace. And very soon, there will be one for survivors of intimate partner violence. And we're really excited about that and would recommend you check back on the CAT website because we hope this will be ready and public probably by the end of the summer. We've had a few delays due to COVID-19, but we're really excited to get this course out there. It's basically 30 to 40 minutes to get all the basics about brain injury and intimate partner violence that somebody working with women might need to know. Now, there are some other resources that dovetail really well with what we've been developing. As I said, the Concussion Awareness Training Tool is sort of a 30 to 40-minute online course. This website, the Abused and Brain Injured Toolkit, was developed by some colleagues in Toronto, and it's a fantastic deep dive into everything you could ever want to know about brain injury and intimate partner violence. There's information for service providers like women's shelter workers and others. There's also information for survivors so they can learn some things about what they may be experiencing and how they might be able to help themselves move forward. And this is another fantastic resource just generally on the topic of intimate partner violence. This book came out in the last year. Rachel Louise Snyder is a professor and a journalist out of the United States. It is bar none the best book I have ever read about intimate partner violence. It's approachable, it's human, it's based in science and fact, and it is, as it should be, it's shocking, but it really is a great education for those who may not have that broad base of knowledge on what intimate partner violence is. It's a very complex and nuanced issue. Highly recommend this book. It does have a small section that talks about brain injury and strangulation in particular. So this is one of those resources that we pretty much tell everybody to read.
Phase 3 of the project is called the Empower phase, and this is looking at a community-based referral support network. So again, first phase is looking at characterizing traumatic brain injury in this population. The second phase is about educating people who provide support for survivors, and this phase is really about directly providing that support and hopefully improving quality of life in this population. So the idea is that we plan to partner with the Community Brain Injury Support Agency in Kelowna. It's called Brain Trust Canada, and the Regional Healthcare Authority to create this support network. Now, this is a very complex and complicated set of circumstances in terms of both the social, cultural, and emotional and psychological things that go along with intimate partner violence, in addition to the brain injury component of it. So by definition, any supports need to be multifaceted and tailored to the individual. Our first step will be to identify the gaps and barriers in what's currently available through surveys and focus groups with both service providers and survivors to get a better sense of where they run into challenges in terms of seeking supports. Then we'll develop and pilot test a community support the community support network model in collaboration with our partners and run some pilot participants through, hopefully later this summer, using a COVID-19 friendly pilot version that would be remote and online. And then measure changes, both in terms of quality of life, resiliency, and self-esteem by surveying the participants, as well as hopefully measure some changes in brain function.
Some of the things that have been proven to work well with people who are experiencing chronic effects of concussion and brain injury are things like exercise, meditation and mindfulness, cognitive functional exercises, and counseling support. So this range of services are all the pieces that we'll be bringing together in this network and providing them specifically to those women who need them to help support them as they move forward.
So what's next? Future goals that we hope to focus on over the coming year to 3 include?
We're working already on designing and delivering some education and training for brain injury experts and other sectors apart from those who are already trained in directly supporting women who've experienced intimate partner violence. One of the key things we realize is that the whole stigma and shame attached to intimate partner violence really create difficulty for some people in becoming educated and even talking about this issue. And if someone isn't trauma-informed and at least basically knowledgeable in the nuance of intimate partner violence, no matter how much they know about brain injury, we don't know if they'll be able to provide really solid support for women who've experienced both. So we are developing a survey that's almost done that we'll be delivering to brain injury experts across the country in the hopes to gather from them what they already know or don't know about intimate partner violence, whether they already use a trauma-informed approach in their practice in supporting people who've had a brain injury, and how we can help them learn more about intimate partner violence as well as the intersection with brain injury.
From a lab-based assessment perspective, one of the things that we're really interested in is examining the potential long-term neurodegenerative effects. You can see from the arterial stiffening data from the cerebral autoregulation measurements that there is some evidence that is likely to be occurring. And so finding other measures and potentially measuring participants over a series of time points to look at potential long-term neurodegenerative effects is one of the key goals for the future. And then in collaboration with colleagues at UBC Vancouver, we hope to start some neuroimaging studies specifically targeting, again, neurodegenerative effects, and in particular looking for probes for chronic traumatic encephalopathy, or CTE, which is a huge area of concern in sport-related concussion and the long-term deficits that potentially arise from playing a contact sport. And so we're wondering if analogous changes and neurodegenerative effects are also present in this population. So with that, we'd like to thank first the funding and support that we've received from a variety of agencies since we started this project, and of course the rest of the SOAR team. This wouldn't be possible without all the grad students and undergrads and trainees and other people that are working on this project to make it happen every day. And of course, thank you for your attention, and we look forward to the Q&A where we'll hopefully be able to answer some of your questions.